All right, let's jump right in and talk about one of the biggest topics in cardiology, heart failure with reduced ejection fraction, or HFrEF. But we're not just going to list off a bunch of drugs. Today, we're going to think like engineers. Our job? To build a powerful, life-saving fortress around a heart that's struggling. So, that's the big question, right? When a heart is an HFrEF, it's basically under constant attack, from things like chronic overstimulation and harmful remodeling. The therapies we use aren't just random shots in the dark. No, they are a carefully designed architectural plan, a blueprint to defend the heart. And let's be absolutely crystal clear about what we're trying to do with this fortress. Making people feel better is great, but the number one goal, the whole reason we build this thing, is to reduce mortality. It's about helping our patients live longer, plain and simple. If you take one thing away today, let it be that. So what exactly is HFrEF? Well, it's a condition where the heart's main pumping chamber, the left ventricle, has gotten weak and just can't squeeze as hard as it should. And the magic number you have to burn into your brain for your exams is the ejection fraction, an LVEF of less than or equal to 40%. When you see that number, it's our green light to start building that fortress. Every strong fortress needs a rock-solid foundation, and in HFEF, that foundation is built with 4 massive pillars. We call it Guideline-Directed Medical Therapy, and these are the absolute bedrock of survival. The term you'll hear all the time is quadruple therapy, and it means exactly what it sounds like, using one drug from each of these 4 core classes. They all work together, in synergy, each one making the other stronger to give our patients the absolute best chance of survival. So let's build it, pillar by pillar. Our very first pillar is beta blockers. Think of these as the giant shields of our fortress. They protect the heart from the constant bombardment of adrenaline. This slows the heart rate, eases its workload, and just gives that tired muscle a much-needed break. And here's a super high-yield tip for exams. It has to be one of the big 3, metoprolol succinate, the long-acting one, carvedilol, or bisoprolol. These are the only ones proven to reduce mortality in HFrEF. Okay, pillar 2. This one is all about blocking a harmful hormonal system called the RAS. Now, the top choice, the preferred agent here, is an ARNI. That's sacubitril valsartan. It's a pretty cool 2-for-1 weapon. The valsartan part blocks that harmful RAS pathway, but the sacubitril part does something amazing. It boosts the body's own good hormones called natriuretic peptides that help the heart. If for some reason you can't use an ARNI, then you'd go with an ACE inhibitor or an ARB. Now hold on, this slide is a huge safety alert. This is a classic board question. If you're switching a patient from an ACE inhibitor over to an ARNI, you absolutely must wait. There's a mandatory 36-hour washout period in between. Why? Because using them too close together can cause a massive, life-threatening swelling called angioedema. Do not forget that 36-hour rule. Let's lay down our third pillar, the MRAs. We're talking about drugs like spironolactone and eplerenone. They work by blocking a hormone called aldosterone. And aldosterone is a real villain in heart failure. It makes the body hold onto salt and water, and even worse, it causes scarring or fibrosis in the heart muscle itself, making it stiff. So MRAs step in and put a stop to that. But, and this is a big but, with MRAs you have to be careful. Because they block aldosterone, they can make the body hold on to too much potassium. You absolutely have to keep an eye on potassium levels, especially when you first start the drug or if you increase the dose. It's a must-do. And now for our fourth and final pillar, the newest players on the team, SGLT2 inhibitors. You'll know them as dapagliflozin and empagliflozin. Now, these were originally diabetes drugs, but here's the absolute game changer. They were found to have a huge mortality benefit in HFEF patients even if they don't have diabetes. This was a massive discovery, and they are now a non-negotiable part of our foundational therapy. So there it is, our completed foundation. You can see all 4 classes of drugs lined up here, but look closer at the chart. Notice the starting doses and the target doses. This is so important. It's not enough to just start a patient on these 4 drugs. The goal is to slowly increase the dose over time, or titrate, to get them to the target dose that was proven in clinical trials. That's where you get the biggest bang for your buck, the maximum survival benefit. Okay, our fortress is built. It's designed to help people live longer. But what about when they feel short of breath or their legs are swollen? What about managing the day-to-day symptoms? Well, for that, we need a totally different tool. And this, right here, is one of the most important distinctions you can make. The 4 pillars are fortress. They improve survival. Loop diuretics, like furosemide, only improve symptoms. Let me say that again. They do not reduce mortality in HFrEF. They are essential for getting extra fluid off, but they don't fix the underlying problem. Here's a good way to think about it. The diuretics are like the plumbing and sump pump for our fortress. They are fantastic at getting rid of water when the basement floods, when a patient has edema or fluid in their lungs. But they don't do anything to patch the cracks in the foundation. That's the job of our 4 pillars. So what do you do when the 4 pillars are in place, titrated up, but the patient is still struggling? Well, that's when you call in the special reinforcements. These are add-on therapies for very specific situations. Let's run through these quickly. First, for self-identified African American patients who are still symptomatic on all the other meds, adding a combination of hydralazine and isosorbide dinitrate has been shown to improve survival. Second, if your patient is in a normal sinus rhythm but their heart rate is stubbornly stuck above 70 despite being on the max dose of their beta blocker, you can add ivabradine to help bring that rate down. And finally, there's digoxin. We can use it to help reduce hospitalizations, but it's really important to remember, digoxin provides absolutely no mortality benefit. All right, sometimes even with the strongest pharmacological fortress, we have to bring in some hardware. For our highest risk patients, that's where device therapy comes into the picture. There are 2 main devices you need to know about. First is the ICD, or implantable cardioverter defibrillator. This is for patients whose LVEF stays at or below 35%. You can think of it as an internal defibrillator, a safety net ready to shock the heart out of a life-threatening arrhythmia. Then there's CRT, or cardiac resynchronization therapy. This is for patients who also have a really wide QRS complex on their EKG. That wide QRS tells us the ventricles aren't squeezing in sync, and CRT uses extra pacemaker wires to get them working together again. Okay, we've covered a lot of ground. We've laid the foundation, installed the plumbing, and even brought in special forces and hardware. So let's look at the final blueprint for success. If there is one sentence I want you to walk away with, it's this one. The job is not done when you write 4 prescriptions. The real art and science of managing HFrEF is in the follow-up, in carefully and slowly titrating each of those 4 medications up to their goal doses. That is how we build the strongest fortress possible. That is how we truly save lives. When you think about it, the development of this quadruple therapy is an incredible success story. It has completely changed HFEF from what was often a death sentence into a chronic, manageable condition. And it makes you wonder, right? As we learn more and more about the heart, what new pillars will we discover next? What does the future hold for building an even better fortress?